Hey GP learners, in this session I'm joined by the team from Eva Healthcare talking about their new products and their new entry into the market as well that's designed to try and help you manage things like vaccinations, so for COVID, flu, and basically it's the alternative to Pinnacle. I know loads of people have been interested to hear about this and we're going to cover it right now for you. So let's tech in hands your primary care and learning. Hey GP learners, so as I said, we've got the team from Eva Healthcare here. I'm going to let them introduce themselves because they're far better at it than I am. So can we go to Maddie first? How are we doing there, Maddie?
Hi, yes, I'm Maddie Phipps-Taylor. I'm the Chief Exec of Eva Health Technologies, which is the latest new entrant into the GP IT space. And we're very excited to be here to share sort of a launch effectively of our product with you today.
Cool, and we've also got Danny joining us as well.
Indeed, I'm Danny Stone, so I'm Head of Marketing here at Eva. So I kind of manage not just external marketing, but also our partnerships, both short and long term. So I've been close to our small pool of customers to date through the pilot, and hopefully meeting a lot of you guys out there in the GP space moving forward as well.
Cool. So I know we're talking about the eVacc platform that you guys have been developing, and I believe you got some awesome news that happened as of last night as well. So do you want to talk us through it?
Yeah, I would love to. So as of yesterday, you are the first people to hear. We haven't even gone live on Twitter or done anything big yet, but we have now got the very much sought after what's called DevMac, so Development Milestone Assurance Certificate, which essentially means that we can now serve you guys. So we can work with NHS GPs, so local vaccination centres, to deliver COVID vaccination recording, and that you obviously all the back end stuff, all the stuff about getting paid, about getting it back to all the central systems, and then getting it back into the GP record is now being fully assured. So as of now, you can ask us to replace Pinnacle, and for you guys it will be free. NHS Digital and NHS England very kindly pick up the tab for that, and essentially we can roll out to anyone who would like to use our software.
Cool. So I guess just for those that don't quite know exactly what that might mean. So many people obviously have been doing and engaging with the vaccination program, particularly obviously for COVID vax for the past 6 months or so. And the main software of inputting that information has been the Pinnacle software, Farm Outcomes, as it's alternately known as. And that basically is how you put the information in. The downside is that software was never really designed for primary care use. It was never really designed for GPs to use. And there have obviously been some pros and some cons of how it's working. And it's nice to hear that there's actually an alternative. Tell us about it, Maddie.
Yeah, it's good to have some choice, right? And for some people, Pinnacle worked really well, and that's fantastic, but not for everyone. And there was it was a one-size-fits-all approach, and I understand that with how the program was rolling, sort of October, November, December time, everyone was working so fast and trying to go with what they had available. And as you say, the Pinnacle solution was there. It was originally designed for flu in the community pharmacy setting, and credit that you made it work, guys. You made it work. You found some hacks, some barcode scanning widgets and things like that. But there was always this plan to bring other vendors into the space, to give you choice, and also to recognize that COVID and flu is here to stay. And actually the vaccination program needs to become sustainable. It needs to become more BAU as we go forward, so business as usual as we go forward. And that won't necessarily always mean that you want to use one solution in every setting, but there could be other ways of doing it better. So that's what we've been building. It's taken us a while, but we've been working very closely with NHS Digital with the changing specifications, and everything that you've learned from Pinnacle has now come into our product as well. So we have learned from their mistakes. So thank you, and hopefully we will be in a really great position to support you guys with the COVID boosters and the flu vaccines, particularly in the autumn. Although, as I say, it is available as of today, which is great. Cool. Shall we take you through a bit of the sort of context as to who we are as a company? Because you probably won't have heard of us before.
Okay. So I'll put your slides up if you wanted them. Yeah.
Awesome. So Eva Health Technologies, we launched last September, and actually it was sort of a restart. So we're a combination of Microtest, who some people may have heard of in the past. We were one of the 4 GP IT practice management solutions. We were the smallest, and we got acquired by Public Group International just over a year ago. And as part of that, we were completely sort of reshaped and reconfigured and rebranded, but really from a fundamental position. It wasn't just a relabeling. This is a completely sort of fundamental restart of the company, and that's what I was brought in to help to do. So what we've got is a really awesome domain understanding for people who've been with the company for 20 years and really understand what it is to support GPs in practice, but also the energy and the dynamism of people who are new to the space, who maybe come from fintech or other health tech startups, and Google and people like that, who actually can bring some of the more modern technologies, which we all know aren't available yet in the primary care space, as you would like to see. So it's a combination of those two things, with a drive to say, actually, yes, we can do things better, and we can build really awesome tech. So effectively, we are a restart. We're quite small, but we've got grand ambitions. And actually what we're doing is we're building reliable AWS hosted tech that you guys can use, hopefully for free when we get assurance, as we have now with our first module. And it's very much a first module in a longer journey for us. We see this as a multi-year project to build something that can eventually, replace your EMIS and TPP systems, or say your DEEM system, the vision system as well, in that sort of longer journey. But it's going to take us a little bit of time to get there, and we could do with your help and support in doing that.
Definitely. Shall I keep going?
Shall we go on to the next one? This is just sort of saying that we're well placed with that background to be able to support you guys in the GP community as you go forward. So we're on the Lot 1 GP IT Futures framework, which means that when things do come down the line, we're able to respond and to put things out in an accredited way. And NHS Digital and NHS England often fund programs that go through that framework. We're only one of 7 who are in that sort of that space that looking at the GP practice management space, although obviously it's flexible and it's moving, and we are a little bit away from being able to do everything that you need to do every day in practice. But we've got access to specifications, and one of the things, so we'll talk a bit about through this session, is not just for COVID but also for flu. So we are right up there talking to the people who are making decisions right now about how you guys are going to be asked to do flu in the autumn, so that we can build something that delivers what you need. So that access into NHS Digital and understanding what's coming down the pipe is really important for us to be able to develop quick enough to put it in your hands in good time. And then this last point here is we're consistently first to reach our assurance milestones. So for us, we are a small, nimble team. We have been targeting this particular sort of use case for a few months now, but we are the first company to have come through every single gate that we got to, every single milestone assurance we got to. We were there first, and I'm really super proud of the team for getting yesterday through the final hurdle, which is what we call DevMac, so Development Milestone Assurance Certificate, and we are the first to do that. We understand that others are going to be coming through, whether that's TPP in EMIS, or whether other new entrants like Medical Director. We were with the same opportunity. We're still there faster, and I hope that's a testament to sort of our level of agility and responsiveness to delivering what you guys need.
Definitely. And an important point is, while we have a grand long-term ambitions to take on EMIS and TPP, and you're about to see our short-term kind of most immediate solution and offering, we are very much all ears on what we do next. We want it to be a partner-led approach with what you need tomorrow, and we'd love to build that with you. So just an important point there. Just one final slide before the demo, Maddie.
Yeah, I think we've covered all of this in bits maybe, but it's just important to sort of come back to, obviously this audience is a very informed audience about GP technology. And I just wanted to sort of reiterate some of the things that we've taken as the sort of the foundations on which we're building. So it is cloud-based and interoperable as standard. We've got, it's AWS, so it does scale as well, so we'll come to that. But the integrations, we've already got 5 national systems integrations to make this solution work. Mostly they are exactly the same ones that Pinnacle are using, because that is the required specification. However, they are the foundation of what we would need to do going forward. So things like GP Connect, the patient demographic system, NIMS for recording, getting access to whether they've had a flu or dose 1 or dose 2 if you're going to be doing boosters in the autumn. So things like that, that's really important. Interoperable is standard, and I think that's something that is fundamentally different from what potentially other software companies will be doing, and we really see that as part of who we are. Quite often we're not going to be the source of the data, and we're going to need to find that data from other systems. So we really want to build a platform really that is good at bringing in data from other sources, but also sharing it back out appropriately, obviously where that is an appropriate thing to do. The next one, scalable, high performance and robust. We have been running now for 4 weeks. We've not lost a single minute of performance time over that period, which is fantastic. It is scaled up. We tested it to 500,000 jabs a day, which is approximately, the whole load of English vaccinations a day, approximately on a good day. And that's even before we've sort of turned up the dials with AWS and started throwing more money at compute power. Just the basics out the box, we can do 500,000 jabs a day. It also comes with robust security that AWS offers. It's modular, so this is our first module, and we'll be building others. So COVID plus flu will be essentially a module, and then we'll be working beyond that. And we'll be able to, once you've got a login, essentially you've got a login to Eva, and you can then explore other modules as we bring them online later down the line. Intuitive design, hopefully you'll see that. I think it speaks for itself, so we'll come back to that at the demo. We are accredited, as you would expect, all the things that make us a legitimate vendor on the GP IT Futures framework, and we are really responsive to feedback. So already we've done 6 releases in 4 weeks. You may say, well, do you need to do 6? It's because we've been responding to people saying, actually, I don't like how that wording is. That doesn't make sense to a volunteer St. John's Ambulance person. Can we change it to make it clearer? Well, yes, we can. And so we've been doing very small, minor upgrades throughout this period to really be responsive to feedback. So that's, I think, all we wanted to share before going over to the demo.
Yep. So without further ado, I will do exactly that. Bear with me.
I guess one thing whilst we're waiting for that to come up, I think that agility is really important because, as you mentioned, although it may sound a lot, 6 in 4 weeks, being able to respond to those kind of changes that rapidly is something that I think many in general practice now hoping to expect from the companies that are providing these tech. We've seen how iterative changes, rather than waiting for big, massive releases every 6 months and stuff, can be so much more adept and agile in terms of the use from the system. So really actually encouraging to hear that that's something that's happening with yourselves and things.
Thank you. Yeah, it's important to have that feedback loop and to feel it's not just 6 months. And if you store everything up for 6 months, it's a really risky thing to do. It's actually perversely, it's less risk to do smaller releases more often because each one is smaller and more contained. So actually it's also less risky to do this as well as being more responsive.
Exactly. So without further ado, can you see the eVacc login screen? Okay.
Yep.
Excellent. So I'll proceed then. So yes, everybody, welcome. Hello. This is eVacc. You're seeing now. We're deliberately starting at the login phase because the magic kind of starts here. Just a little caveat that the platform you're seeing is a demo platform. It's pretty much 99% exactly as the live platform. But there may be a couple of small things that you might notice that we'll talk over. First things first, Dr. Paula Peterson is not a real doctor. The amount we've thrown at her the last 6 months, she does replicate a real frontline GP in many ways. But yes, we'll go through straight away just to show you. So once logged in, it's important to note that we work on a role-based access kind of approach with all our users. So you as a user would log in using one simple username and password, but then depending on different sites that you might be at, the access could change. For example, you're seeing here 2 dummy sites, one of which Paula is a vaccinator and another she is a healthcare professional supervisor. This is really important because it means you don't have to find your ODS code when you're logging in if you're at different sites. And genuinely the feedback we've had from this is that it's it's made life a lot easier on the ground, which is obviously wonderful to hear.
Yeah, so no more ODS codes. No one's trying to remember ODS codes. And also we're going back to your original ODS code, the one you originally got at the start of the program, because that's actually your master ODS code according to the NHS. So you don't need to even remember the subsequent ones that you have. So if you've got volunteer staff who are forgetting every week what their ODS code is, no more. They just need to know the name of the site that they are working at. That's all they need to know.
Exactly. Awesome. So once logged in, we'll take you through this fairly slowly. I think one thing to reassure you on is that, again, the feedback we've heard from the ground from our pilot is that they think we're saving around 20 seconds for every single jab compared to their Pinnacle workflow, which obviously is amazing news to be told. You won't necessarily see us flying through this now for the simple reason we want to make sure that you see how the system works in its entirety. The first thing is obviously is in terms of the patient search or registration. So obviously we know there are different ways of doing this. The idea would be an integration with the booking system, and we're working hard to do that as quickly as we can. It wasn't a prerequisite of the spec. So for simple reasons of getting us through assurance, that hasn't been done, but we know that would be an awesome thing to do.
We're working with NHS Digital on that, but if anyone wants to go and contact NHS Digital or any of the booking systems and ask them to make this happen, we would be grateful for that.
Yes.
Thank you.
We're all in this together. For now, the assumption would be that you have someone in front of you, would know their NHS number, or at least you would barcode scan or QR code scan their details. We can support that. I don't have a barcode with me, Maddie does, but it would be as simple as this. You would put the NHS number in, very slickly, this person would come up in front of you. You confirm that this is your patient, and then you move straight in and you're into this person's essentially miniature health record. So obviously you can see that Hardy and Core here, again, a dummy detail, but we have a true almost dummy NIMS integration, if that makes sense. So you can see that we can see their previous immunization records that are relevant. You can see that they had flu at the back end of last year. And importantly, they've already had a dose of COVID vaccination this time around. And that's important as you go through the workflow. So once we're all happy that we've got the right person in front of us, we simply start the workflow. You'll see straight away that a deliberate design principle has asked us to squish all the information to the left. You'll see that build as we go through. You'll also see, again, a deliberate principle here is that there are a few very small stages, but they are split deliberately. That's because we know that different workflows work in different ways in different vaccination sites. You may not even know that. We do. We speak to a lot of vaccination sites on a nearly daily basis. And what it might mean is that you have a different person doing a different job at a different station, or you might have one person doing all the jobs. This caters for both, which is awesome. You'll see straight away, this is the additional information questionnaire, essentially, in form. Again, if there's anything you don't see in Pinnacle, that may also be because we're slightly ahead of them in the spec, interestingly, obviously. So likelihood is if you can't see this currently and you think it's additional, it will be coming, especially in time for flu season, we imagine. You'll see straight away, and this at the end, at the top of each of these forms, that the assumption here is that for the time and date stamp as the here and now, if for any reason you're clerking at a later date, you can actually override it, but we'll assume that that's the here and now for this instance. And then, simple background and additional information. Are you a carer, social worker, healthcare worker? This is quite late to be added to the specification, but obviously is very key to know. You can actually, as a rule, we've tried to reduce the amount of clicks wherever we can, and hopefully you can see that throughout. The assumption will be for these that it's no to all. And then you can search through, again, through your ethnicity. I know on Pinnacle that you can just type the letter. Again, it's all about saving seconds, right? And you can do that with us as well. We'll assume that this person is Indian. We'll save. Again, this is the point I was making before. You can either save if you know that someone else is going to pick this up at a different station. We'll assume that this is the same administrator or vaccinator doing the whole process. So in this instance, we'll just save and proceed. And as you see, as I've mentioned, it squishes to the left. So if for any reason you were picking this up at a different station, you'd meet the same screen. So we'll keep going. So we're now into screening and consent. So what's this person coming for? I wonder if they're coming for their first jab. Well, no. Thankfully, the clever bots at Eva have worked out that via the NIMS integration, if we put in that it's the first jab, obviously it's pulled through that they've already had a Pfizer first jab, so it flags it up here that is likely to be an error, and we'll actually change it to be their second jab.
And actually, just interestingly on that point, Danny, that was one of the things that we've had feedback on from clinicians. The frontline staff doing the vaccinations might not necessarily pick up that that's such a vivid thing. We've actually tried to make the warnings even more vibrant, and we're considering whether we actually need to, if you want to override it, you have to go through a flow and actually agree that you know that you're overriding it from a clinical safety perspective. So we've had quite a lot of clinical safety input on those warnings particularly, and there may still be things that we can do better, and we'd love to have feedback on that to make sure that you are reducing the risk for clinical issues to occur like that.
Definitely. Exactly. So for this instance, we'll assume that there's no override needed. We're moving into our Hardian's second jab. In terms of clinical screening, again, the assumption here is that they're toggled off as a rule, and you can tick on if for any reason any of these are applicable. Again, there's different prompts essentially come up dependent on what the screening challenge is. Again, for this, you can proceed as long as you've confirmed it's safe, either with a lead clinician or just when further assessment has happened. For this, we'll just assume that there are no exclusions or cautions, and we are happy to proceed based on the assessment that's been done. We all know we do have to, obviously, even though they're sat there in front of you, officially speaking, you do have to give consent, especially if for any reason this person wouldn't be, but if they're underage or whatever, you may need to make a note that it's their parent or guardian who gave the consent, or power of attorney, or things like that. So we'll move on. There's a space for notes that would go here, and then we'll assume that we're okay and we're moving forward into the actual administration. So once again, squish to the left, all there for you. You can reference it easily on the left. You can go in and edit it as well should you need to. Now we're into the administration. You do have to confirm that you've done the essentially the record check that you've got the right person in front of you, and then we're going in to the actual administration itself. Who's vaccinating it? It's going to be myself as Paula, but you can obviously assume that it might be somebody else. The batch that we're choosing, again, for this, we'll just assume that it's Pfizer, the same as the first batch. We'll show you the batch management for vaccines a little bit later. And then more important information here is on the drawing of the vaccination cells from the vials. Again, you have to specify. We'll assume in this instance that it's someone different. It's Dan Danderson, great man. And he's also done the drawing up. So he's responsible, but has also done the drawing up himself. Then into the vaccine delivery. So again, which arm? I've actually had both my jabs. Maddie, interestingly, was the first person to have a jab on the eVacc platform in our pilot site.
I was the guinea pig. I was the very first person to have my medical record stored in eVacc. So if you want to ask, would you do it yourself? Yes, and I have.
Yeah,
thankfully, I was very appreciative, and we'll come to our pilot site and talk. We can talk in a bit more detail, maybe in the question section, about our first site, and they've been absolutely incredible. Big shout out to the Crumbles Vaccination Centre in Eastbourne. They have been fantastic for us.
Yeah. Absolutely, they've been amazing. I've had mine on my left arm. That would be the assumption. Obviously, left and right arm are there as kind of shorthand prompts. You can choose other injection sites. We know that realistically, that's most likely to be thighs. It's not the arms. Well, again,
but for flu, we're ready. We're prepped for flu. If it's a nasal routine, we can deliver that as well in our solution. That's not a problem. And all of this gets SNOMED coded in the background and fed through to the central systems. So all of that is coded information when it comes to data and interoperability.
Exactly. So we'll assume that the injection has been successfully administered and completed. Somebody might faint or something, so actually you might have to come back to this or even just finish it with a no. But we'll just assume that we understand and we've gone through we've given the information to the patient. Any additional notes, again, would go at the bottom. And then simple as that, we're done and we're saved. So there is, that's a typical encounter. We'll show you adverse reactions as well in just a second. And again, obviously, just to reiterate, we've gone through this very slowly with you guys, but we are saving versus Pinnacle, certainly in our pilot site, around 20% on average. with time, we want to make that a little bit more scientific. It is fairly anecdotal at the moment. We're very proud that the information came to us from our pilot site. We didn't even push for it, and that's wonderful to hear. But we want to get a little bit more scientific with our next few sites launching over the next few weeks, just so we've got more solid data to share with you guys. Anyone else have anything to go? Any questions or anything from you two before we go into into the adverse reaction?
No, I think if we show the whole platform, and then we'll go to the Q&A from there.
Wonderful. Cool. So, we know this is going to be quite a rare instance, but we do have to record adverse reactions. I'm sure everybody will be used to this. So again, if it's me as the assessor, as Paula, I've noticed that Hardian has maybe had some dizziness as a result of and we think we can attribute it to the jab. We'll just need to note down the severity, whether we can attribute it to an allergy or an intolerance, but that's optional. We don't have to click that. And again, you can override the onset time should you wish, but it's set to the here and now. You can actually add multiple adverse reactions if so needs. Again, for this instance, we'll just assume that it's just one and no additional notes. So that's an entire patient encounter. Again, just I guess probably easiest, we'll keep going and just show you a couple of the super admin kind of features. Maddie, do you want to say something? Sorry.
Yeah, so I was just going to say, off the back of that, as you would expect with Pinnacle and from a national program, essentially all of the data flows happen automatically. There's some things that happen with a 15-minute delay, just in case if you made a quick mistake and you recognize it immediately, you want to go back in and edit something, then there's a natural delay. So we're not sending sort of instantaneously sending it downstream. However, within 15 minutes, this is essentially getting to the BSA for processing your claims. And also overnight, it's actually in the evening, twice in the evenings, we're sending it to other systems, which mean it gets into the GP record, typically with less than 24 hours to get into the EMIS and TPP practice records for these patients. So we haven't actually, interestingly, we haven't tested it with a Vision site yet or a Sajadine site yet. If you are a Sajadine site and you want to pilot it with us, that would be great. Just let us know. We just haven't come across one yet. But yeah, all of the downstream stuff happens automatically. You don't need to worry about it. Yeah,
absolutely. So we'll go, as I mentioned, we'll go into a couple of the super admin features. So first of all, very important is kind of the batch management portal. And, as you can see, this is toggled straight in terms of the vaccines that are actually available. So these mimic the two that you saw on the list earlier. Obviously, we know that some you would have in stock but on hold and therefore unavailable, but you can see them all just by simply clicking at the top here, including ones that have been used in the past. Obviously, it's a dummy.
Or expired.
Or expired, exactly. I was about to say that our system has a lot in there, but I imagine a lot of the vaccination sites will be even more than this. So in terms of adding them, again, it can be done via barcode scan or simply manually, as you can see here. I won't go through a whole one because, again, you'll be very used to this. We've had some really good feedback, again, on how our batch management works, just for its simplicity. I don't know if, Maddie, you wanted to speak about that a little bit based on the Crumbles feedback?
Yeah, so I mean, they really enjoyed the fact that when you get a load in, a delivery, you can preload them into the system so that they're all there. They're just on hold, so they're in stock but unavailable. And then as you go through and you've defrosted, you've drawn them, and then you can say actually this one has been is made unavailable, and because it's no longer in stock, it's been depleted. That was a really simple sort of way to think about stock control, and it helped them at the end of the week when they were doing a stock check as well, just to see which ones they already had available and preparing ahead, and obviously thinking about how that links to releasing appointments as well. We're looking in our next version to just do a count of how many vaccines have been drawn from each batch that's in our system. So if you said I've drawn 100 from this batch and I had 120 that I was expecting to get from it, then there is a bit of variability whether you get 6 or 7 out of a vial, but at least you'd be able to do sort of the mental maths on, okay, how much approximately do I think I have left in this batch, which could be really helpful to just planning that bit further ahead and making the sort of end of day process a little bit easier. Mm-hmm.
Absolutely. A couple more very quick things before we take questions. User management, fairly straightforward, but also quite, very, very easy to use. So obviously we know, for example, I think we're approaching 200 users within only 4 weeks at the Crumbles. So we know there's a big effort in terms of manpower, and actually it could be a bit of an administrative nightmare. Again, we've had really good feedback on this. Adding users is very simple. You simply add in their email address like this. They'll then get a prompt to reset their password and they're in. And then us as supervisors, or as super admins as we call them, you can obviously have control from here. So you can toggle them on and off, first of all, and then just simply amend their user-based access. So it's important to know, obviously, a vaccinator will have different levels of access to a healthcare professional or a healthcare professional supervisor who basically has free reign on the majority of the software. Really important, but as I hope you can see, really simple user experience and very easy to manage just bit by bit. So yeah, just important to note. And then the final thing is just on reporting. I know this is evolving, but Maddie, do you want to maybe talk through this a little bit, especially with regards to the BSA stuff?
Yeah, so I mean, obviously we've had a lot of feedback from people that sort of the data getting out of the system at the moment is quite hard to do, and you're downloading it maybe in chunks of 20,000. There are essentially all the downloads we have at the moment. We have a few in the system. They're the same format because they need to be the same. If you ever had an issue with the claims, you wanted to submit manually to reconcile any issue. Not that we've had any issue, but you may want to do that. But actually, our next version of the software is going to have much more intuitive reports, so you can pick a date range and the sorts of data you want to extract. The core ones is sort of essentially the happy path. So everything to do with a patient is going to have be defaulted to reduce the amount of PID, so that it's unique and identifiable, but without first name, surname, any of their contact information, just because it's good principle, obviously, to not be downloading a lot of patient identifiable data. But that will be around vaccines, who delivered the vaccine to them, what batch. So if you ever had a problem with a particular batch and you really needed to get in touch with people quickly, then that makes that a lot easier. But also doing a separate report on adverse reactions, because again, if you wanted to be doing analysis around, do you have any issue with adverse reactions, either from a particular vaccinator, a particular drawer, or a particular batch, that could be an analysis that you'd want to do, and will help support you in doing that. There are obviously all of this data does go through down to the downstream system. So if there is another issue with a wider batch number or something like that, then obviously they have that data available to analyze and get back to you. On this BSA status, this is a live updating. So essentially you can be sure of what has gone through the system and what hasn't. If someone has started the process and abandoned it, so it's not a complete flow, then you will see that in these numbers here. So BSA not claimed. And then you can go on the next version, you can double click into it and it will tell you which records are currently in sort of a stuck status, so that you can, at the end of the day, you can work out what maybe that patient walked out without getting a vaccine, or maybe actually someone just didn't complete the flow. We spent a lot of time trying to make sure that it's hard to do things wrong in the system. It's hard not to get to the end of the flow if someone doesn't consent, or it's not safe to proceed, or the vaccine wasn't successful. Obviously, they're the unhappy paths, but we've done quite a lot to make sure that is reduced. So it's maybe less than 1% of the time that you have something that an administrator may need to go in and look at. We're also in the next version doing care home and other settings, so roving, homebound patients and things like that, for which you get paid a premium, and we'll have that in the system so that you'll be able to claim those enhanced payments as well. Indeed. That actually went live last week, but it's not in this demo system right now. And
I guess before we finish, just a bit of a final note on flu. Obviously, what you've seen so far is a COVID workflow. And yeah, we're extending to flu. And we know that there's still some uncertainty around exactly what will happen. There's still some clinical safety work around whether the jab can be administered twice, or rather together, whether that means in one jab or in two. We obviously know also that flu is quite tried and tested at practice level. So we just want to give you the choice, essentially. And we're working with clinicians to find out how we can best do that, whether it's the instinct is to toggle on, toggle off, whether you need to do both, one or the other, or whatever. And either way, I think the main thing is we're here to make sure that we are being more efficient. with this software, providing software that is benefiting what could be a really a humongous inoculation season this winter. So yeah, we're listening and trying to work out how best to do that with your support, essentially.
Cool, thank you. So, I mean, that was a really detailed and thorough presentation, I guess, of the platform and stuff. And I guess the parts that I particularly like is the ease and the basically the cleanness of the interface. The fact it's just so nice and simple to use, but also that attention to clinical integrity and data, and making sure that there's as minimal errors as possible, and hopefully none by the looks of it with that kind of workflow that you've got. So it's got that combination of nice and easy to use, but also safe, for lack of better terms.
Good. Well, I'm glad you appreciate that, because that's definitely what we're aiming for. And we had a lot of great inputs. We have 2 UX UI designers, so user experience user interface designers, who have done a lot of testing. We've watched videos of people. We haven't let them watch any training materials. We've just given them, please try to log in with these details. Please try to vaccinate someone called Jared Howe. Can you do it without any instruction at all? And they can. We record them doing it, and we're like, and get them to talk about, so I'm worried about this. Oh, does this button do that? It's awesome user testing, and it really has helped to make it a bit more fail-safe. We're still dealing with humans, but trying to make it easier and fail-safe is really an important sort of design principle.
And I think one thing that was really interesting was, in the build up to the pilot, we kind of challenged the team to say, look, can we train this system, or can this be learned in 10 minutes? And that sounds like a lot, that sounds like, a huge challenge, right? And when you think about, change management, and then you think about 10 minutes, it sounds a bit, like a paradox. Actually, what we found was that with our pilot site, people were learning it in more like 3, 4, 5 minutes. It was amazing. Like, people were teaching each other. We became pretty redundant as a team. We were there. We became pretty redundant after probably the first day. And the pilot site moved the whole system over from Pinnacle within the first 48 hours. So, it's awesome, basically. So, really intuitive, really easy to use. But as you say, marrying the two up between safety and simplicity.
Cool. So I know normally at this point we take on some questions and stuff. I'm more than happy to take any that we've got from the chat. I know prior to this event, I've had a few people contact me saying that they wouldn't be able to attend, so they've kind of sent me their questions. So I'm going to pass those over whilst we give the opportunity for anybody else to chuck in some extra ones and stuff as well. And you kind of half answered my first one, which was, in terms of if somebody was looking at onboarding and starting using this platform, how long does it take for them to switch on from a systems perspective? And then secondly, I think you kind of answered this one, how long does it take for the individual user to onboard with, using eVacc and basically getting up and running and stuff?
Shall I take the first half of that, which is sort of the sort of process point? So we are now available. I don't know if you missed that, but if you weren't live streaming from the start, but we are now available to the NHS GP-led, so local vaccination centres, not the mass vaccination centres just yet, but we're working on it. So you can sign up today, and we will work with you as fast as possible to get you going live. The first available slot we have that, if you wanted to go live and you said, yes, I really want it, would be next Thursday. So, next Thursday you could go live, the 1st of July. In terms of a prep from our perspective, we have there's a quick form that, like you did with the booking systems back in sort of December time. There's a form you need to fill in, NHS digital website, which will be going live tomorrow, hopefully, if they've done it. And that will be a very super simple, just this is who I am and this is what I want. I agree I want to sign up to Eva. We will then do a very quick call to walk you through sort of making sure you've got the information. We obviously give you, the DPIA, our clinical hazard log, all the stuff that you would expect from a clinical system to be able to say, right, yeah, I can understand the risks that I'm taking, as with any system. Not sure if that happened with Pinnacle back in the day, but it should have done. And then we do typically a 1-hour super admin training. So whoever at your site, your clinic, whoever's your sort of tech savvy or IT lead, if there's more than one, then awesome. Someone who is able to say, right, yeah, I can see all aspects of it, and very similar to what Danny's just done there, but a little bit slower and really focusing on user management, batch management. So it's about an hour for super admin training. And then after that, it's really about sending out emails to your staff saying this is coming, expect to see it in your inbox, and then onboarding individual users with their their email address, which is about 30 to 60 seconds per user, depending on if they can remember their professional registration number, which is obviously sometimes something that people don't. So if they're sitting in front of you, type in your email address, very simple, mostly your NHS email address, and then can you remember your professional registration number? That professional registration number is only for those who are clinicians, so not your volunteers or your healthcare assistants, but it is important because it does get into the record, and if there should ever be an issue and we have to dig in through the logs, then obviously that is all recorded appropriately. So that's the process of recording. It's about probably 1 hour for the super admin training, about probably another hour of filling in a form and sort of engaging with us on a time frame that sort of when do you want to go live.
Yeah, and in theory, like the process could be, you could do it in 24 hours. The main thing is just aligning diaries of the key people. There's nothing, we're a cloud-based, system, no download. You can log in wherever you want. So in theory, and it takes us, it's a click of a button to actually get you live and get your center live. And yes, so it was all very quick. And as we've already mentioned, training is very quick. It can take 5 minutes. We have a load of training materials online. Lots of people are confident enough just to go in, give it a play. We can also set up a demo environment for you, and then they get the confidence within 5-10 minutes, and you're away. So yeah, very quick.
Cool. You mentioned about being cloud-based and everything. So I guess, is there any element of device restrictions? I'm thinking particularly the mobile clinics, all that kind of stuff. Is there anything they just need to be aware of, or is it just it should work as long as you've got a decent internet connection?
Decent internet connection and not on Internet Explorer. Nothing works on Internet Explorer. Nothing modern works on Internet Explorer, so please don't use it. But yeah, basically any browser that's not Internet Explorer and any device. We wouldn't recommend on a phone unless you really had to, because it just makes it look really small. And if you want to you'll be scrolling a lot. But on tablets, it works really well. So we've had our pilot site is using iPads, and it's been working really well for them.
Cool. Yeah. Okay.
It is a responsive design, so it does scale to whatever screen you've got available.
Awesome. So I guess the next question I've got then, you talked about system integration. It kind of works in the back end with EMIS, System One, or all that kind of stuff. Obviously, part of the changes that are happening this year is that particularly the flu is being pushed into the PCN kind of domain in terms of QoF, QI, and all that kind of, and the impact and investment fund. That's the word I was looking for. So obviously, ifs. So many practices are potentially now considering actually delivering these kind of schemes cross practice, cross systems, maybe an issue with that kind of stuff. Just to check, because I think it does. This works irrespective of that, doesn't it? 100%. Yeah. Cool.
So this is agnostic to whichever system you're running it for, a GP practice record system. So one of the three you're running, and it's got this. We want to be building a concept of a patient list, because then it can help with things like did not attends and stuff like that. We can start to be clever about helping you plan ahead for the rest of the day, if we know who you're expecting. However, at this point, it's basically a temporary registration for any patient who's got an NHS number. And actually, you can do any patient that doesn't have an NHS number as well. So it's a little bit harder to claim your payment, FYI, because they want to make sure that this person legitimately doesn't have an NHS number, because obviously we want everything to get back to the NHS record, and that requires an NHS number. But essentially, it's any patient who you want to deliver care to. If you're delivering a vaccine, whether that's going to be flu or COVID, then you'll be able to do it in our system, which means that you can do it at a PCN level, or sort of a cross-boundary level, and it's an equally good experience for every patient who turns up to that clinic. It's not like saying I've got a host clinic, a host practice, and basically I'm temporarily registering people who aren't with that practice. With that practice, if you see what I mean. So it's trying to just take that hassle and stress away, but it all gets back to the practice record as long as there's an NHS number through the central clearinghouse, essentially, of DPS.
So if I could push you a little bit more on that point then. So imagine if you were setting up a mobile clinic to do the flu vaccines and the COVID vaccines in September time, cross PCN, that kind of stuff. You set up a walk-in clinic and you have somebody turn up and they don't have an NHS number. How complicated is that?
Well, so you'd be doing a PDS lookup, so patient demographic service lookup, as you would do in Pinnacle right now, and presumably they know their name and address. But if they don't, some of them don't have addresses. Actually, we found there's something like 60,000 people in the country who've never had an address on PDS ever.
We found 2, didn't we?
And we found 2 of them. That was an interesting day. We're like, really? Anyway, you had to put in, then you had to substitute the ZZ99 postcode, which is the sort of not known postcode. Anyway, that's a technical detail. But for example, if you have, say, a community either of people who perhaps are undocumented or are maybe a traveling community who don't have residential addresses like that, then you're doing a normal PDS lookup. And ideally, if you can find someone that matches them, you have to match 1-to-1, right? You can't have they could be this person, they could be that. You've got to have a 1-to-1 match. If you find the 1-to-1 match, totally fine, and then it's going to process accordingly. That might take somewhere between 1 minute and 5 minutes, depending on, if you have to try maybe their maiden name, or maybe they've changed something else recently and not updated the NHS central systems. We, unfortunately, at this point, we can't change PDS. So we've got read access. We haven't got write access to PDS. Okay. So if someone says, actually, I've moved, or I've got married and changed my name, or I just changed my name, then we can't, unfortunately, do anything about that in our system. But we would recommend that they go and talk to someone in their GP practice and get it updated via the GP practice. But it should take 1 to 2, maybe 3 minutes, depending how complicated it is, to do a PDS lookup. And once you have that information, you're away, and it's just as you would expect.
Cool. Okay. So you talked about, obviously, the fact that this is for COVID vaccinations and for flu vaccinations. I guess moving forward, other vaccinations, child IMS, shingles, that kind of stuff,
yes,
is that on the cards?
And this is where it would be great to get some engagement from your community of interested GPs as well. So we are definitely doing flu. We're actually contracted to do flu as well, which is fantastic. And I think that comes around every year, so that's helpful in terms of building some momentum and becoming part of the infrastructure, I suppose, of how you deliver seasonal vaccinations. After that, we can do other vaccinations pretty simply, and I think there's quite a lot of things that we can see in that space. We've had whether it's the sort of catch-up campaigns that you may want to run in the community, or whether that's catch up within the school communities as well. Potentially that would be something, if someone wants to work with us on scoping that out, that would be awesome. We're also thinking, as part of our journey back to being a full sort of GP practice management platform, we're thinking, okay, we need a number of things that come next, and we're working with a number of sort of very progressive and engaged CCGs and PCNs, and ICS is actually one ICS who just wants to say, right, I know I want it now, but I can't get it now, but I'm willing to work with you to try and make it happen in the future. I realise that you can't do everything today, but let's help work together to do it in the future. So things like asthma, hypertension, and the health checks are also on our list to be working on in the autumn. We're going to have to make some decisions as to which one. We're sort of still assessing options and seeing how interested people are. If you are interested in any of those and you want to vote, put in some comments on the live stream, or get in touch with us afterwards. So things like asthma, thinking about managing it in the community, something that sits across a PCN potentially, so not just in a practice setting. So be able to group it together. Perhaps you want to bring together a team of people who are specialists in asthma care, or that you feel that there's a greater efficiency and therefore you'll be able to reach a wider population of people if you were to bring it together as a central hub, and that you want that central hub to be using software that really supports them in what they're doing. That would be awesome. So we're looking at, how do you get more information from the patient directly? How do you change forms more quickly, so it's effectively it's a forms-driven protocol? How do you make the form more responsive and quicker to fill in? How do you display whether it's your heart rate or your weight or your smoking or your alcohol intake? How do you start to display that in a more helpful way and engage the patient in self-care? So those are the sorts of things that we're thinking about now, and we'd love to work with people on.
Cool. So it definitely sounds like the future is looking bright.
Yes, the future's looking bright. The future's looking like Eva. We hope so. I mean, it's a long journey, right? And but we're committed to it, and we see every day we're like, we can offer something here. We can help. We can do better. We're thinking through, our data model and our data sharing. I know you guys have been very, interested in obviously data sharing and sort of patient consent and things like that. Going forward, actually having a platform that helps you to deliver operationally a sensible data sharing strategy. That's the sort of stuff that we would love to get involved with as well. And we're actually talking to NHS Digital about that. How do we create a data model now and a patient model? Like, who owns bits of the patient data, and who can share, has a right to share with whom, for what, and how can we communicate that back to the patient? So these are the really big long-term goals that we'd like to be a part of. And we see there's definitely space in the market for something a bit different.
Yeah,
cool. And you mentioned, obviously, you've been working with some partners already. I think you mentioned the Crumbles practice or something along those lines.
The Crumbles Vaccination Centre in Eastbourne, yes.
That's the one. Yeah, there we go. Can you give us, I guess, some examples of how it's been working, some results, that kind of stuff? And I know, there's things mentioned earlier and stuff. So I guess
I can indeed. Yeah. As if by magic, I do have some. Bear with me a second. I'll bring it up. So we entered into what's known as a kind of controlled go live, which for the layman, I guess, is just more of a pilot phase 4 or 5 weeks ago now, just with the one site in Eastbourne. We have to say to Mark Cannon and the team, just like, thank you so much. I mean, ended up being the absolute perfect pilot partner. I can't stress that enough. In terms of their boldness and their willingness to try it, their communication and everything. But look, but this is all about the Eva team, really. And, I've not been involved in the actual product itself. So such huge kudos to these results, because as Manny's already mentioned, we've said some of these a few times, but we'll just reiterate. We haven't lost 1 minute to downtime. We know that's a big issue with Pinnacle. And actually, we grouped these into actually things we wanted to achieve, essentially, and some wrongs we wanted to right. So 0% downtime, as we've mentioned, 20 seconds per jab being saved. Over, getting close now to more like 16,000 vaccinations, including over 1,200 in one day, and getting closer to 200 users in the system. And as we said, we're built for scale. 100% accuracy with the BSA payments and claims coming back. I'll just skip to the thing about upgrades. We've now done 6, as Manny mentioned. So we're being really flexible. We're listing lots, and we're always improving. I think user experience, as Manny's mentioned, is quite hard to quantify, but a little bit of feedback directly from this is from day one in Crumbles. And it was lovely to hear. I think Manny was beaming when she heard, people vaccinated telling other vaccinators just how simple it was. Don't worry, it's a new system, but it's really easy to learn. That is absolute music to our ears, because we know how difficult it is to bring software into the NHS. And I think the big one there at the end is trust. Now, I know that the vaccine effort's been awesome, but I think a little bit of trust with Pinnacle. I wouldn't say it's 100% levels of trust and confidence. And for us to have, I was hoping from a marketing point of view that the site maybe over the course of a month or so might move over, having, tested the waters. But they were so comfortable that after about 6 hours, they were saying to us, look, how quickly can we bump this up? So I think the call came in after 24 hours that we were going to do this. And by 48 hours, the whole site was on eVacc. And interestingly, one of our other pilot sites, Pinnacle, went down in the morning on their day one of their trial. So they moved to eVacc just for the day, but we were there to save the day, albeit just one day. So that also brought a bit of a smile to us that, you can toggle on to us whenever you need to, which is obviously nice as well. But those are the main results that we're really proud to share with everyone today.
Cool. So I guess just summarising that from my perspective, you mentioned obviously it's reliable, which I know with primary care systems is always a frustration, because it just makes your day go awful if it just goes down when you don't want it to. And obviously we can't do anything unless these systems work, or the other workaround is paper, which is a nightmare. And I guess that 20 seconds saving per jab, that's a big one for me. Most of the hacks I try and share with the EGP learners often only save them about a few seconds per repetitive task. 20 seconds, that's significant time saving when you keep doing it, task on task on task on task. So awesome.
And we do have to caveat that there are different workflows, right? So we've encountered a couple of workflows that this is the caveat here is that this is fairly anecdotal and for one site, But the most of the demos we've showed people, they instantly see that the way we're set up is the same as the crumbles. We've had a couple of that aren't, but yeah, awesome numbers.
Cool. And I guess, so with all of that stuff, if people were interested in looking at, signing up with eVacc, signing up with Eva Healthcare and stuff, where would you signpost them to?
Go to evahealth.co.uk/eVacc. Oh, look, there it is. Here's what you made earlier. It's down here. Yeah, I mean, there's a mini sign-up form there. There's more information. There's videos for you to peruse. Go through the contact us page as well if you want, or just danny@evahealth.co.uk or hello@. I'd love to hear from you. We're starting to get more and more people come to us from various avenues, and we can handle the scale. So, and it's just such a perfect time to speak to us about eVacc and beyond, right? We've been very head down on the product. Our first module as Eva, and that only really came to an end yesterday. So it's such an exciting time to speak to us because we're excited about the future and we need partners. So yeah, ideal.
And now
time.
is a good time to switch, right? Because I know everyone's like, well, maybe it's the end of the program. Why are you launching now? But it's going to come around. Winter is coming, as they say in Game of Thrones. Winter is coming, as it happens to do every year. Actually, if you're quieter now is a good time to switch ahead of the busy season coming in September.
And that's what we found. A couple of the sites going live over the next couple of weeks are doing exactly that. They're finding a quiet time to trial this, knowing that it's going to do the job 100% that Pinnacle's doing, and it might just be even better once they work out what they want to do with flu. And that would be the biggest encouragement we can say to you is why not try it? It's very low risk. What we do as well, just from a trial point of view, we just do one pod. If for any reason anything goes mental, you can literally just revert back to Pinnacle in the click of a button should you want to.
Well, it's just opening a different tab on your browser, right?
Literally
different tab on your browser. That's how easy it is to fit back.
Dual running is allowed for up to 4 weeks. So again, it gives you plenty of time to trial it and decide if this is for you. We can't imagine anyone would want to use both at once anyway. So that's plenty of time to decide whether you're in with eVacc or you want to flip over. So it's been set up in a way that it's for new clinical technology, very, very low risk to trial, and it's free.
Cool.
So yeah.
Awesome. Absolutely. And as we mentioned earlier, if you do want to check it out, feel free to check out the links down below. Obviously, if anybody does have any questions come out after the stream and things, more than happy to signpost them back to Maddie and Danny and the team and stuff, and definitely check them out. As always, each of you, if you do have any comments or questions, feel free to let me know. More than happy to try and answer them. And as usual, we're here to help tech enhance your primary care and learning. And we'll catch you in the next episode. See you later.